Good evening, everybody. It's really lovely to be with you, and welcome to our marvelous guest, the Uber South African scientist, Professor Glenda Gray. Very welcome. And Mark Heywood, our editor-in-chief of Maverick Citizen, and obviously a long-time activist for social justice. It's a very big day that we mark here, colleagues. 100 days. I can't believe that it's 100 days since March the 5th, when the gentleman came back from Hilton, when he came back from Italy to Hilton, and that marked the first notifiable case in South Africa. It seems to me, and I'm not sure about you, like everything in our country is different. Like we sit on the precipice of great fear, but also of great potential. And I very, very much look forward to our discussion tonight. So I thought I might go back with you a little bit and begin to understand when this COVID-19, SARS-CoV-2, the coronavirus, first came into the public imagination. I was in Cape Town on holiday, on honeymoon actually, and I started hearing news about something was happening in China. Then got back to work early in January, and I remember all of us being invited to a press conference by the health department, the health minister, and the National Institute for Communicable Diseases, who were going to tell us about this new virus. It was very early on, months before we had our first case. And what I wanted to ask you both first is, what did South Africa get right at the beginning? I think that as an institution, the NICD has managed things very well, but that's just my perspective as a journalist. And as a country, could we start there first? What have we gotten right as we stocktake these first 100 days?
So I think the government started preparing very early, and as you rightly say, the NICD were very busy. There were management teams put together and interministerial committees, and so people were planning. And so when the first case happened, this put in a whole lot of processes to implement the process and to start managing the epidemic. In the beginning, obviously because of the cases, it was easy to track and trace and contain the first group of travelers that were identified as having COVID-19. And so I think that the response was very good in the beginning, and that the government and the NICD responded appropriately and made good plans to move forward as the epidemic unfolded in South Africa.
Glenda, if I can ask you, how did you get that? Sorry, Mark, coming to you now. How did you get that first call to be part of the scientist team? Because obviously, for me, that's been one of the more marvelous things to watch, where science and politics work together. I know there was a kerfuffle, but really, it's been a good alliance to manage the coronavirus. Tell us about that first call, if you can.
Yes, this happened on the Monday before the lockdown. And there was a call, the National Department of Health called a whole lot of scientists together. We attended a meeting. Professor Olive Shazana presented some strategies and the plan around the testing. There was a lot of engagement. Shabir Mahdi was at the meeting. We were talking about testing, talking about approaches. A lot of clinicians were there. They were concerned about PPE. And so there's a whole lot of dialogue and a whole lot of discussion. And then afterwards, the MAC was established towards the end of the week.
Ah, okay. So that was quite a quick movement. Mark, what's your assessment of the first 100 days? I mean, Maverick keeps power on its toes, and you've been right up front leading us with that. I thought I'd get your big assessment first.
I think it's difficult to give a single assessment of the first 100 days. I think there are some things that, as a country and as a government, we have done exceptionally well, that have made us world leaders in certain respects. And there's some things that we've done terribly badly. And I think there's a big gap between the political commitment and the execution in certain respects. So, all congratulations to President Ramaphosa. When we were dealing with the HIV epidemic, and Glenda and I were in those trenches together, we talked for years about the need for political commitment. It was this holy grail that you had to fight for. Well, we had political commitment to COVID-19 literally from maybe not day one, but pretty much from, within the first 2 or 3 weeks, government woke up very quickly and moved very, very swiftly. So we have to be very, very thankful in that respect. The other thing that I think is, which you've mentioned, is again, HIV ironically helped us a little bit with this, is that we have a body of scientists, of clinicians, of researchers, probably second to none in terms of developing and middle-income countries. And we have institutions like the National Institute for Communicable Diseases. So theoretically, at least, we stood on a very good foundation to begin to tackle COVID-19 when we became aware just what a threat it was to the country.
Thank you for that. So when I look at the charts, I must say, for the first time, Africa and South Africa are not top of the leaderboards of the bad news story. So 7.7 million cases, you were saying today, Glenda, 430,000 people tragically dead. It's going to scar big parts of the world. In our country, 65,700 cases as of yesterday, a little bit more, 1,423 deaths by the media release I got last night. So that's a lot of people, and every death is a death too many. But we are in the best cases in the world: South Korea, Taiwan, maybe Singapore, all of which have had secondary infections, I know. What's your assessment of those global statistics?
So I think at a global level and at local level, every country has been devastated. So there is no health system that has managed this onslaught, and there is no economy in this country at a global level that has not been affected. And so at a global and a local level, wherever we are, there is both devastation of the health system and devastation of our economy. And we have not escaped that. South Africa is behaving very much like a low middle income country setting in the epidemic. And so if you look at the various epidemics unfolding throughout the world, and you monitor them, you see that we haven't really followed the developed world pattern. We are much like the low middle income countries, and we've not yet peaked, and that's a very important thing. So the low middle income countries are still surging, and they haven't peaked yet, and we're not sure when they're going to peak. We also it's also very hard to understand also in low middle income countries actually the extent of the epidemic. We're all under testing, so there's a very little penetration of testing in our settings. There's global shortage of testing, but in poor countries we are under-penetrated. We're not getting enough tests per 100,000. So it's very hard to understand that we've seen the tip of the iceberg, and so we're not too sure what's happening. If we had to scale up testing to the kind of levels that other countries, other developed world countries have done, we may see a different picture. And so I think we are underestimating the epidemic. We know we have a testing backlog. We know that we compete globally for testing for reagents, and that at a global level there's a shortage of testing. And so there's a concomitant impact in poor countries where it's hard to navigate the processes to get enough testing into our country.
That's interesting. So that's almost just over 200,000 cases across Africa. Mark, what's your gut telling you about testing? Is it the low testing numbers masking a much bigger epidemic?
I think the low testing numbers are masking a much bigger epidemic. Of course, it varies very much from country to country. I hear people like Glenda, Shabir Mahdi, talk about our confirmed cases versus the likely size of the epidemic. Sometimes people say it's probably 4 or 5. I've even heard some people, not necessarily Glenda, say 10 times bigger than the numbers that are coming up through the tests. Glenda said tip of the iceberg. Ferial, I think there's just no space for complacency. I remember chatting to Glenda a couple of months ago and saying, why is Africa behind the curve? Is there something? And there was speculation for a while. Was it BCG vaccination? Was it the fact that we have a younger population? Why was Africa not apparently affected? But I was reading an article this morning suggesting that this epidemic appears to be taking off in parts of Africa now. And things are going to change tragically. And that's a terrifying scenario because, you know, outside of a few countries, I mean, we complain about our health system in South Africa, but at least we have a health system. There are many countries that barely have a healthcare system at all. And if this epidemic behaves like it's doing in Brazil or Peru, in Ecuador, then we're in trouble. The other thing I think is when it comes to South Africa, and I mentioned this to you, you know, we are, I looked at a chart today, based on the number of confirmed daily cases. South Africa has now the 8th fastest growing epidemic in the world.
Wow.
Based on the number of daily confirmed cases. So we were hoping, we were
highest
praying.
number. Wow.
It's the 8th. I mean, yes, that has to be further interrogated because there's so much that we don't know, but I'm afraid that we're moving into the serious COVID-19 epidemic league.
And it's just at the moment where the country seems to be relaxing. So when I go up the road here or to my mom in Mayfair and Fordsburg, it's almost like it's at level 1. People have had enough after 100 days. There's this fatigue which sets in, but yet this is the moment, perhaps, Glenda, for heightened vigilance. How would you advise?
So we don't have any way of managing this epidemic besides using non-pharmaceutical interventions. And so we need social distancing, we need hand washing, and we need to wear masks. We know that the closer you are to people for extended periods of time make you more susceptible to acquiring COVID. We also know that if you are close to someone and you're with them and they're shedding, and you get exposed to the droplets and you touch your face, you're more susceptible. So we have to. Well, the only tool we've got, we don't have an antiviral and we don't have a vaccine. So the only tools that we've got is the social distancing, 1.5 to 2 meters. Spend very little time, get out of congestion, wash your hands, wash the surfaces, and wear a mask to protect yourself and to protect others. And that's our tool. And if we implement those tools, we know that if you implement non-pharmaceutical interventions, you can contain it. We've seen in Seattle with the implementation of NPIs that they were managed to reduce the cases, and that they managed to control levels to get to the endemic phase. So I also think we need to know is that this is not going to go away at the end of November or end of December. We know that these epidemics, that coronavirus circulates for 2 to 3 seasons. And so as we move from our peak, we're going to get to what we call our endemic phase of the epidemic, which means that this epidemic is going to go on for months into 2021 until we find interventions like vaccines.
Thank you. So many questions. We're joined by 1,613 friends. Welcome, Philip. Nice to see you. Rebecca, Beulah, welcome. Question first from Rebecca, our colleague. Question for Dr. Gray. It's been suggested by some actuaries that the projected death figures of 40,000 by November are implausible due to the young population. What's your view? Another question on death rates at the same time. Can we trust the numbers that we're seeing?
So these are all models, and as you've heard before, and as you've heard scientists say, your models are as good as your inputs. And so when you make these models, you're putting inputs that are largely at this current stage in South Africa unknown. So we know how many people died last year and the year before, and we know the kind of deaths that will happen due to respiratory illnesses. And we can look at what's happened in the first 100 days and try and model. And our model, right. And then you'll have a variance in your model. So I've seen figures from 20,000 to 40,000, and so you take the low margin is 20,000 and the high margin is 40,000, and you work in those areas. And it's important to understand that, because we're going to have other deaths. We're going to have deaths due to HIV, deaths due to TB, and deaths due to influenza all at the same time, and we're going to have to try and differentiate what death is from which disease. And so we can expect an increase in mortality from four deaths, 4 communicable deaths: TB, HIV, influenza, and COVID-19. And so it's very important for us to track these deaths, and we have been tracking them on a weekly basis to try and understand. It's also good to know that during the lockdown, we did see a decline in non-natural deaths. So the lockdown, the curfew, and the prohibition on alcohol reduced violent deaths, car accidents, and deaths due to alcohol-related down. And we also saw that we reduced hospital admissions and emergency room admissions. And so if you ask about what were the good things that we did, and in the first 100 days was what we did do is we kept the emergency rooms open, and we kept them open because people weren't drinking alcohol.
And you can see those numbers coming up. From Badrashil Modi, numbers of infections are going up. It seems that nothing except lockdown works. He doesn't believe that testing and tracing and isolating is working. What's your view, Mark?
Look, testing and tracing and isolating is not working because it's not being done properly. If we were testing in a sufficiently targeted way, if we were getting the results of the tests within 2 days at a maximum, if we were able to quickly contact, quarantine people who test positive and quickly trace the contacts of those people and test them and so on, then that would be one of the best strategies that we have. You know, the lockdown.
And you say we're not doing that. Huh?
Well, we just have to have the capacity, you know. So first of all, we have a delay in our test. You know, we have a huge backlog in testing, and so if tests are not turned around within 48 hours, and we're testing, we're running tests that are very old. It's very hard for someone whose test was done eight days ago to try and track them and then find out who they've seen in those 8 days. Yeah. And so track and trace is important. You need to be able to turn around your tests immediately within 24 to 72 hours to really impact. And we know what to do. I mean, so at this stage of the epidemic, the most important thing for us is to understand who is COVID positive, who've been admitted. So of the persons under investigation, it's critical to know who is positive. And it's also important to know which of our healthcare workers are positive. And so we do need to reserve our tests now for the emergency, and the emergencies are hospitalizations and our healthcare workers. And we will need to put community-based testing on the back bench while we respond to the medical admissions. So we're in another phase of the epidemic, which is the medical or the mitigation phase. This is where we've seen the cases, the sick people who are coming to hospital.
But isn't that a cruel dilemma, though, Mark? Is you need to test, you need more community testing, but yet because of the shortages, we have to test the emergencies which are appearing in the hospitals. How are we going to get that accurate picture?
Well, we won't get an accurate picture to begin with. I mean, we're going to have to wait for an expanded testing capacity. We're going to have to wait until we have some antibody tests available so that we can get a better sense of the prevalence of COVID-19, people who perhaps have already been infected in the last couple of months. I mean, it's perhaps not the subject for tonight, but one area where I think many of us feel our response has failed or has stumbled has been on this question of testing. And we have to continue to monitor it very, very closely. But I want to go back, Ferial, just to one point. Yes. That you raised the question, this person who said lockdown, and it seemed that during lockdown we were interrupting new infections and almost suggesting we should go back to that. Yes. I don't think it helps to suggest that, you know, if we go back into some sort of level 5 strict lockdown, that we're going to get this epidemic under control. What we have to do now, and this is what Glenda and other people are saying, is take very seriously the advice that government and healthcare workers are giving about social distancing, about hand washing, and all of these critical interventions, because that's all we have. And what worries me is that, as you said, Ferial, I mean, I was out riding my bike. Every morning I go running. Probably 50% of the people that you see, some of them don't even pretend to have a mask as they're running. I think there's going to be, we need some peer pressure. We need citizen pressure. We need people calling other people out and saying, hey, you know,
Where's
do
your
you think-
mask? Yeah?
Yeah, where's your mouth? Do you think that you are immune? And even if you think you're immune, you're still a danger to me. Do you understand principles about social solidarity in our community? You know, the onus is on all of us to spread those messages, because we cannot go back into a lockdown. People are starving because of the lockdown. People are desperate because of the lockdown. That is not an option at this moment in time.
I want to come to what happened to our economy. Sorry, Glenda, you're going to say, and if you could just also respond to the view that many of the tests we have done are pretty useless. You shouldn't clog up the system trying to get those through. It's better to do new testing. What's your view?
So I think we have to understand that at a global level, testing is in crisis, and
Yes.
there are very few countries that have been able to respond appropriately, and maybe Singapore and South Korea were one of them, and places like New Zealand and Australia. But largely, even the US suffered and fell behind with testing, and they could never go to the scale that we need. And so at a global level, testing is always going to be a problem, and it's going to be a problem in all poorer countries. And so we have to understand, the limitations of the testing, and then we have to given the limitations of the testing, we have to make sure that we prioritize. Given that the fact that we have so little tests at a global level,
yes,
we need to prioritize that testing. And at this stage of our epidemic in South Africa, we should be prioritizing our healthcare workers, our laboratory workers, our first responders, and the people who are in the hospital who are under investigation for suspected COVID infection. And we have to not clog up the system so that these people can be managed properly, and that we can then contain people who are positive, and we can manage people who aren't in different ways. And so having limited testing means that you have to be nimble in your response, and you have to put your testing into the right for the right response. And so we have to look and say, what is the utility of doing a test that is 8 days old, and what is the utility of doing something that is 10 days old, and also to be honest with our public and say, we are sorry, the epidemic is out of our testing capability can't match the demand, and this is what we have to do. We have to protect the people in the hospitals and protect the healthcare workers, and the public will understand that. And then it's about communication and building public trust about our ability and our resources to do this, and to also acknowledge that countries suffer. We're probably the only country in Africa that can test as much, and at a global level we're suffering. And so because of this, we do have to make sure that we use our scarce resources in the best possible way.
But is that system failure, Mark, or is it just a global backlog and rich countries getting in first? I really want to talk about that a little bit later. Or does it say things about the lack of cooperation between our private labs and our NHLS? Could you just share a little more light before we go to some more questions? Yeah,
it's both system failure and poor planning. There was poor planning by the NHLS in a critical early stage. And we'll talk about that at some point. It's also about inequality. The private sector turnaround time at the moment is 1 to 2 days for their COVID-19 tests. The public sector turnaround is 8 to 9 days. Why is it that there's that difference? But then there are big system questions, and we keep asking, what will we learn from this epidemic? Well, at the moment, we are held ransom by the fact that there's half a dozen private companies in the world that produce these tests, and we are all dependent on a few private companies, and that points to the fact that over the last 20 or 30 years, there's been a systematic disinvestment in public health, in preparedness for epidemics, and putting our lives literally in the hands of a few very, very, very profitable companies. And so you take something, Glenda could explain this better than me, but we have a wonderful instrument for testing in South Africa called the Gene Expert. We use it for TB. We have them all over the country. We have more than any other equivalent country in the world. but we can't use our gene expert because we don't have the testing kits to put in the gene expert, because those are all in other parts of the world. And so a bit like with antiretroviral medicines, where you are having to say, well, why can't we break the patents and produce these locally because lives are at stake? One of the questions I'm asking myself is, are we going to learn a lesson from this? Why aren't we trying to rapidly develop reagents, testing kits at a local level or in other developing countries, so that we're not held to ransom?
Surely that must be the next big struggle after this one. Obviously, I think people, Glenda, are really thinking about issues of mortality. So many questions on deaths, if I may go through some. Lavinia, welcome. Sondru, welcome. From Jonathan Rees, what's the age profile of the people who are dying? And is this data informing our response? From Andre Kurtzen, how sure are we that all deaths are because of the coronavirus? And there have been several like that. What are people really dying from or of?
So we have seen, like with the rest of the world, that the older you are, the more likely you are to die. We've also seen that comorbidities are associated with death, and we've seen a huge association between diabetes and death, and hypertension and obesity and death. So we have seen, like the rest of the world, the comorbidities, the non-communicable disease comorbidities impacting on it, and the older you are, the more likely you are to die. We also have seen that HIV has impacted on mortality as well, and so we do know that we need to ensure that people who are HIV infected understand their vulnerability, and also make sure that they are taking their treatment and they are able to access care early. And so we are seeing, in the Western Cape, that it's people over 55 and people with comorbidities. We know that there are in the Western Cape people that are disproportionately affected, and because of the comorbidity issues, people with diabetes and obesity. And so we have to understand, who's vulnerable, and that is also the response. And I agree with Mark about the social solidarity. We know that the elderly and the vulnerable are more likely to be impacted than the young. And we need to make sure that with intergenerational households, that we protect the elderly, and we know who in our workforce has comorbidities and the age of our workforce, so that we can make mitigation strategies to minimize harm for people that need to go back to work. We also know that people need to be well versed in the symptomatology and understand when to access care, and understand if they are progressing, and that's important in terms of education. And so we do need to watch. We do have the good news is we have a youth bulge in South Africa, and so we may see different patterns, but obviously patterns. The natural history of COVID disease in Africa is unfolding, and so we are learning as things happen in the country. And so we have to also try and evaluate, as one of the listeners has asked, one of the viewers has asked, how do we know what people are dying from? So we had to re-look at the death certificate, and we really had to design what you put for COVID, because we also were seeing that it's possible that you may over-report COVID or you may under-report it. So we have to make sure we differentiate, and so we've had to start training doctors about what to put on the death certificate, if it's probable or possible. Sometimes people wanted to keep the death certificate while they waited for the results to come back, and we've educated doctors about calling it possible, probable, or definite COVID, based on where you are and the symptoms that you've seen. And so it's very important for us to make sure that we describe on the death certificate what people are dying from. We're also trying to understand what happens in children. We know that in children in other parts of the world, that they have a kind of Kawasaki-like syndrome, and so we're trying to understand a little bit more about the disease, about the disease manifestation in children, and what are their risks. And as I said, we're going, the lockdown and the attempt to flatten the curve has put us right into the middle of the flu epidemic. And so as we open up the lockdown, we enter winter, and we enter the flu epidemic as well. And so we must make sure that we try and differentiate deaths from influenza as compared to deaths from COVID-19. So it's very critical to try and understand the complexities, particularly as we move into winter.
Thank you for explaining that. I didn't know how the death certificate can be classified in different ways. So Mark, this view growing that we should just go back to lockdown. But actually what we saw with the hard lockdown at 5 was it almost immediately revealed every single vulnerability and structural inequality of our economy. So millions of jobs lost, all informal sector or casual workers almost immediately on the streets. And as the Jeremy Seekings document has shown us, the hunger, I think, has shocked many South Africans at how close our compatriots live to hunger. Could you share with us just some of what happened in those moments to inform this view that, no, actually, we shouldn't go back to a hard lockdown and a fully closed economy?
Well, I think that, to be honest with you, when we did the hard lockdown, we were not prepared to mitigate the consequences of the hard lockdown. In fact, at the meeting that Glenda mentioned on the 23rd of March with the Minister Mkhize, where Dr. Shikana presented the lockdown, quite a number of the doctors in that meeting were saying, yes, we do need to do this. This is a way of interrupting infections, but its success depends upon two other critical prongs. One was the ability to immediately upscale testing effectively, and the second was to introduce immediate measures to mitigate the pain and suffering that would come with a basic and economic shutdown. Now, it took us another month before measures like the COVID social distress grant was introduced, the child support grant was increased. And in fact, and you refer to this report by Professor Seekings, you know, the tragedy is that not only did the lockdown make people more food insecure because they lost jobs, it actually took away sources of food, existing sources of food that were coming to people through government. So I know, for example, you know, the NGO Social Movement Equal Education has just filed court papers to reinstate the National School Nutrition Program. That program feeds 9 million kids. And for the last 10 weeks, those 9 million kids have not been getting the 1 square meal a day that they would get whilst they were at school. So, Ferial, we literally have some starvation out there. I mean, Glenda Gray, you know, talked about this issue of severe acute malnutrition in children. In this suburb where I live, Orange Grove in Johannesburg, you know, people don't think of Orange Grove as a suburb which is characterized by informal settlements or whatever. It's a settled suburb. The Community Action Network in Orange Grove reports feeds over 1,200 people just in Orange Grove alone. And those were people who were able to feed themselves 3 months ago. So we have to, I mean, the terrible choice government faces is how do you take this drastic, direct, necessary action to contain this epidemic, but how do you do so in a way that doesn't create a wake of destruction, social destruction? And the question we all have to ask ourselves as the people of South Africa is, what are we doing to ensure people get food, to ensure people keep their jobs, etc., etc.
So that very good document by Professor Seeking says the UIF immediate release of money and the redesign of the system worked quite well, but the feeding schemes haven't, and the 350 Rand COVID grant has just been a disaster. Maybe 7 million people applied, and when last we heard from the president, 130,000 had been paid. Even if you double that, it's not even close to the need. So from Kumran Padiachi says, what about social solidarity? Looking at the Netherlands, New Zealand, Vietnam, it seems that in part the cooperation, solidarity of the nation plays a large role in managing the spread. Are we getting this right? Either of you?
Yeah. And I think we have to keep on explaining, what we need to do. So the country brought into lockdown, and there was a lot of solidarity. Everyone understood, everyone got it, and everyone knew why we had to do it. But at the same time, the social compact between the citizens and the government, we also had to make sure that people got relief. They got food and they got water and they got their grants that they needed to survive this period. And so we've seen the queues for food in the country. We know that households are distressed. We know that even middle class households are distressed. We hear every day about people losing their jobs and being hungry. So the hunger and the lack of resources is pervasive in South Africa, and it's pervasive outside South Africa as well. If 1 in 5 children in America under 12 are going hungry during COVID, what is happening in the rest of the world? So we have to understand that there is global hunger, and even rich countries and better resource countries are failing. So we should know that we are not exceptional in our failure to support the poor. And we need to make sure that in terms of the solidarity, besides implementing the non-pharmaceutical interventions, every able-bodied person that has some resources needs to support people who are hungry and who are struggling at this time. Things are going to get harder. We can't go back into a hard lockdown because people are distressed, and so we have to go out, implement NPI, and we have to help the people that are not doing as well as us during this period. And people are going to be suffering. It's going to take us years to recover from this epidemic. We don't have the fiscal resilience of Germany, and we don't have, we were already in a recession before this started. And so to think that this is not going to affect our economy for years to come is futile, and we need to find ways of moving forward in a way that protects citizens by implementing NPI, as well as protecting the livelihoods and supporting people who don't have any more livelihood.
So, Mark, we've reached a point now of the great social justice cases where this is going to court. But please do tell us where you see this will move to, because I think we're not even beginning to understand just how deep this crisis is, and the levels of very basic need that you're seeing if you're watching the work of the community action networks, the soup kitchens, etc.
Well, Glenda just said things are going to get harder, and I think that needs to be a message that everybody who's listening and watching this and the whole country needs to understand over the next couple of months. We may have gone to level 3, parts of the economy may have been restarted, but there are millions of people who have fallen out of the economy. You take the food parcel thing, the Solidarity Fund distributed 280,000 food parcels in May, and mostly in May, but there's no more food parcel distribution by the Solidarity Fund. It's now moving to a voucher system, which is going to take time to get up and running, and so on. So it's likely that there will be more acute hunger in these winter months of June and July and August. And given that government is failing so badly, and let's call it out, it's failing so badly to address this aspect of the crisis, we have to ask ourselves as people of South Africa, what can we do to assist that? How can we use this crisis to give birth to a fairer South Africa, to solidarity, to sharing? In my middle class areas, people still stock up their supermarket trolleys as if there's no crisis, but there's a crisis right outside their door. So start thinking about buying for another family at the same time as you buy for yourself. There is generosity out there. Ferial, I wrote an article a month ago about a food kitchen in Alex, and the article was about how the scheme was feeding 600 kids a day, but I hadn't been able to get 4 big pots because they needed big pots to cook the meal. And in the 3 weeks since then, there's been an outpouring. If you go and look at that little
Do they
house
have the
now.
pots?
That's a
They
fact.
don't just have the pots. They have like a fully fledged kitchen.
That's fabulous.
But that's fabulous. One story. What I'd like to see is that being repeated 10,000 times across South Africa. And what I'd like to see, we know there's been a great wellspring of generosity of many activists, but there's also a lot of people who are still standing by and just letting this thing unfold as if it's somebody else's problem. We need those people to come in now and have a total social response to this crisis. If we don't have that, this country will fall apart in under the strains that are coming in the months ahead.
Well, that's quite a statement. Sorry, Glenda, yes, please.
We need to reconfigure our values, both at a global level and at a local level. You know, the value of social, social solidarity, the value of that a human life is sacred and is worth preserving, and the issue on equity. And this we've seen at a global level and at a local level. Our values around this epidemic have been found to be wanting. We hear both locally and globally cases of police brutality, that lives don't matter, that people can't access healthcare, and we need to address this both at a local level and at a global level. Is that we can't live like this anymore when there's so much disparity, and we can't accept how human life is treated in all parts of the world. We know whether it's the US or whether it's South Africa or whether it's India under lockdown, when people had to walk thousands of miles home, who are migrant workers without food, and this kind of man's inhumanity to man, we have to address at a global level and have global outrage.
Absolutely. I've been so deeply saddened to read about the toxic lockdowns and the human rights abuses. We were on a call with human rights, Mausi Shagun, who is the Africa head for Human Rights Watch, and she said you've actually got a human rights pandemic at the same time. And in our country, it's equally sad for me to find that we are one of the most over-policed lockdowns, and yet such tremendous ineffectiveness at the social relief end. It does tell you about where money is spent and where power is held, perhaps in the governing council, or what's really just a cabinet subcommittee. It does make you wonder about where that power lies. But I did want to ask both of you, is if we're going to begin talking about sowing the seeds of a better value-based future, isn't this a good moment to begin thinking through what a national health initiative might look like? When we chatted earlier, Prof, you were saying that we need to put together that private-public sector compact really quickly, because people who need ICU beds have to be sure that they're going to be there for them, whether they are poor people who can only use the public health system before, or whether they are people on medical aid. Have we made those kind of accommodations and local compacts for this urgent moment yet?
So I think perhaps one of the shortcomings of the first 100 days of the lockdown has been, the lack of a concrete public-private partnership. And as the days are unfolding in the Western Cape, we're hearing that we're closer to attaining a strategy for public-private partnerships, and hopefully this will reverberate province to province. But it's late in the day. It's late in the day to not have got this completely nailed down, because people are needing care, and so I'm heartened to hear that we're close to having this response in the Western Cape. I do worry about the other provinces, and I worry about the financing of the public-private partnership. But what is important, whether you're rich or poor, whether you've paid your medical aid or you've never been able to afford to pay a medical aid, you should have the right to an ICU bed. And it's our job as the health system and as health practitioners to ensure the right of someone to access the best kind of care in this time, and we have to pull all our resources together. We do know there's a shortage of ICU beds. I think we've got about 7,200 ICU beds. Most of them are in the private sector, and that's why these negotiations are critical. We also have to find ways of making sure that people are not gated from access to any kind of care, and that no one is turned away. And that is why it's very important for us to find a solution and to make sure that the poor can access the best kind of healthcare and are not expendable because they don't have medical aids. And so I do think that we need, as an urgent intervention, to have a full understanding and a full process of unraveling and ensuring that there's a public-private partnership that is patient-centered, that is around patient care excellence, and that both public and private doctors come together, and the public and the private hospitals come together with the public hospitals to deliver the kind of care we want in a post-COVID situation. So this is a way of trying to find a new health system, and not a health system that is the lowest common denominator, but a health system that aspires to the best and the greatest in the world. And we have the most wonderful doctors, both in the public and private sector, who are highly capable, and who are also highly mobile as well. So we need to keep them in this country, who can respond in a way, because we took our Hippocratic oath. We have an obligation to support humanity and our citizens.
And I have a question from Theory Kasuta, which fits in here with you, Prof. I think it's based on a News 24 article which said only 350 ventilators have been amassed in this period of lockdown as we prepare. Do we have enough ventilators? Because I think that was the additional number acquired, not the total that in the country. Huh?
Well, I think there's a lot of things. Do we have enough oxygen? Do we have enough high nasal flow oxygen? Do we have enough CPAP? Do we have enough ventilators? And we know we have to either make ventilators in South Africa or we have to import them. And the last time, I think just at the beginning of lockdown, when we were looking at and when the Solidarity Fund was looking at purchasing ventilators, it was going to take 120 days to bring them into the country. And then we have to look at local, what is our local innovation? We have highly capable engineers and people who could assist in making ventilators in South Africa. We've seen a lot of innovation. I'm sure you've seen the kind of innovation that both Spire and the Solidarity Fund have developed, things from Intubox to novel CPAP and high-flow nasal oxygen. And so there's a lot of innovation. There's a lot of clever people in South Africa who can support it. We should be making our own ventilators in South Africa, using our own resources. And I did in the beginning of the first 100 days, there was there was an announcement made that there was going to be a collaboration between the Square Kilometre Array and local industry to make the ventilators. And I think we should find out how that has progressed, because we need it now. We need the ventilators. So we need everything from oxygen to ventilators and ways of delivering oxygen. We need to also make sure that we're measuring oxygen saturation. That people who are suspected of having COVID have their oxygen monitored to make sure that they're not progressing and getting worse.
Well, whilst we're waiting for Ferial, I just wanted to add one point to Ferial's last set of questions. When we were having this discussion about citizen action and government failure, somebody said quite strongly on the chat, government has to, citizen action can't be a substitute for government, and it can't. And so we have to make government do its job properly. Accountability, openness, transparency, anti-corruption in this period is absolutely critical, which is why, I'm 500% in support of Equal Education's court case to demand that the school feeding scheme be reinstituted with immediate effect. Government has to do that. It has the resources. It has the capacity to do these things. The other thing I wanted to say, you know, Ferial asked you, Glenda, about the opportunity to build a decent, fair, equal healthcare system. I think the same question needs to be asked in relation to almost every area of life in South Africa. COVID-19 poses that same question. COVID-19 forces us to fix our schools now. We will not be able to go back to so-called normal schooling in public schools if the schools continue to be broken, because those schools won't be able to social distance between learners. They won't have extra classrooms. They won't have water. So now there's an absolute imperative to do all those things around school infrastructure that people have been asking for the last 10 years, and to do them in the next 6 months, because that's the only way poor kids will get back to uninterrupted schooling. So the choice that we face is either, if we continue as we continued before, we're going to find South Africa, which was the most unequal country in the world 2 months ago, is going to be the most unequal country in the world times 10 in 6 months' time, if we don't address these inequality driving factors in the COVID-19 epidemic. So it really is a time for a complete reset of so many aspects of our life. So sorry, that was a mouthful, but I don't know if Ferial.
Yeah, we can no longer afford to have this dual economy, and we can no longer have this disparity and this inequality at an economic level. So we can't, we have to keep our children in school. We have to find ways of ensuring that they're safe in school, and we have to feed them. And it's not just the school-going kids; it's the 3 to 5 year olds that need to be fed, and it's the babies that need to be fed. And so we have an obligation to our next generation. We have an obligation to make sure that they are protected, that they get the right education that they deserve, and that they have the right to food as a fundamental right for them to thrive. Children who don't have nutrition can't thrive. We deprive them of their full potential if they're starving.
While we're waiting for Ferial's sound to come back, I'm going to become Ferial for a couple of minutes, because we only have another 7 minutes left. So Glenda, we started this webinar talking about the first 100 days. I want you to tell us about the next 100 days. What should people be expecting between June the 14th and August or September? What is this epidemic? What do you think this epidemic is going to look like, and what are the challenges that we now face?
So the next 100 days are going to be very sobering, Mark. We're entering into the surge part of the epidemic. We're entering into the phase where people are filling up hospital beds and ICUs. And so, as you know already, that the Western Cape is the first province to experience the surge, and we're hearing reports of the Eastern Cape and of Gauteng. And so we have to brace ourselves for a medical onslaught that our hospitals will have to try and be prepared for. So we have to brace ourselves for the medical part of the epidemic, and I think it's going to be brutal for the healthcare workers. I worry that the healthcare workers are not going to have enough PPE, and I worry that our patients are not going to get the kind of care they have because of absenteeism, people being burnt out, the mental anguish of having to choreograph illness and the lack of resources. It's going to be devastating for our healthcare workforce, as well as the patients. People who are sick with COVID can't have their loved ones near them. They die alone. The way we can't bury them like we normally do. So so you can't mourn like you normally mourn. And so not only is the health setting going to be devastated, but our own rituals around how we take care of our loved ones and how we manage them on their deathbeds is taken from us. And so I think that it changes the whole psyche of a nation, and we have to be prepared for that as well. So we have to continue to protect everyone. We have to continue to try and make sure our hospitals are open, that we don't run out of equipment and doctors and nurses. And at the same time, we have to prepare for devastating bereavement, and the way we manage death and dying in this country. And so I think that, and at the same time, besides the medical tragedy, we're going to see other tragedies, the hunger tragedy, the loss of job, the loss of hope. We're already seeing intimate partner violence. We've seen women being hung from trees. We've seen, female violence towards women. That is going to resurge, and so we're going to see a lot of angry and upset and sad people in this country, and we have to be prepared for a different kind of South Africa. But there's also, I also believe that with all of this, there is always hope, and that we need to also dig deep into the character of the South African, the character of our citizens, and to find that humanity that will help us get through this terrible sadness that we're going to see.
Thanks.
Am I back?
Good. Okay.
Can you hear me? That's great.
Yep.
So thank you very much for holding forth there. We have exactly a minute left. So many questions. Maybe each of you could take this. And they're quite practical. When is the peak likely to happen? And is Gauteng ready? Okay,
so we don't know when the peak's going to happen. In low middle income countries, it's very hard to understand the peak, and we don't know when the peak's going to come because we are underpenetrated in terms of testing. And so we can say we're in the surge, and we're not. People predict that. Okay, so Western Cape will peak first, and then Gauteng Eastern Cape, and then Gauteng. But we don't know how long those peaks are going to last, and we don't know what the peak's going to be. We just have to continue to implement our non-pharmaceutical interventions, and we've got to make sure that our hospitals are open and ready to support those that are ill.
So Mark, for you from Lindumaresk, very inspired, I think, by what you said earlier, that we really need to dig deep. How can we make a difference tomorrow?
Well, we can all make a difference. And I see somebody on the chat says, sounds like no hope, actually very depressing. It's going to be very challenging, but I don't think people should take away from this webinar that, we should all be paralyzed and debilitated. There's things each one of us can do in our everyday lives in relation to food, in relation to education. There's a million places to volunteer in relation to demanding accountability and transparency of the state. We have to support our government, but that doesn't mean that we won't be critical and that we won't ask hard questions. We won't tell them when they're doing wrong. We've been challenged before. I mean, Glenda could tell you. Somebody asked, will we have 40,000 deaths? Well, we'll have 80,000 TB deaths, whether we like it or not, this year in South Africa. So we need to look at the whole disease picture, the whole health crisis picture, and perhaps say to ourselves, how are we going to build a better country out of this crisis? Because
absolutely,
that's the best hope we have.
Yeah. So South Africans are resilient. Sorry, that's going to say that South Africans are resilient, and we have lots of hope, and we can do it. I do believe that we can dig deep.
This is 10 years since we pulled off a World Cup that nobody thought we would. I know this is a very different challenge, though. Thank you, Mark Heywood, Professor Glenda Gray. Thank you to the Konrad Adenauer Stiftung for sponsoring the evening. And I thought we might just end with a short moment of silence for the 1,423 South Africans who had passed away yesterday. If you could please join me in bowing our heads. May they rest in peace, and thank you all for your time.
Thank you.
Thank you.